This is essentially a revision for the SCA. So let's go through this compendium of guidelines. So this is like essentially a website I created to help me in my day-to-day consultation. But at this point in time, I feel like my exam is just a week away, and I just want to, you know, actually scroll through and see if there are a couple of information that I can grab will actually be very helpful. So this is the red whale. HRT prescribing, of course, common symptoms of HRT will be things like hot flushes, night sweats, menstrual irregularities, sleep disturbance, dryness of the vagina, loss of libido, mood changes, swing or low mood, cognitive disturbance, joint and muscle aches, urinary problems, vaginal dryness. So essentially, what are the things you will want to offer? So lifestyle modification, things like regular exercise, healthy diets, body mass, weight management, advising patients to stop smoking, cut down on alcohol to less than 40 units a week, avoiding symptoms triggers like spicy food, relaxation, stress reduction, sleep hygiene. Of course, the main thing there is hormone replacement therapy. And then there are some alternatives to HRT that we need to be aware of, things like SSRIs, SNRIs, clonidine, um, of course, CBT for low mood and anxiety, isoflavones like soy and black cohosh may help with hot flushes. So the patients might actually come and tell you that they're already taking some of these alternative medications or substances like black cohosh and soy. Or they might ask you about it, and you need to tell them that, okay, that's actually been shown that some people can make them have some benefits with their hot flushes. Contraindications to HRT, history of breast cancer, estrogen-dependent tumor. Obviously, you have to be discussing that risk with the patient. Untreated endometrial hyperplasia, undiagnosed vaginal bleeding, uncontrolled hypertension, arterial thromboembolic disease, current or recurrent VTE, unless the patient is already anticoagulated. Thrombophilic disorder, so there's a thrombophilic problem, the patient is prone to developing clots, like the factor 5 Leydig mutation, factor 3 factors, protein C, protein S deficiency, antithrombin 3 deficiency, some things like that. Patient has liver disease with abnormal LFT, then of course you need to be speaking with a menopause specialist before you can comfortably prescribe HRT. In terms of counseling the patients before starting them on HRT, things you need to be telling them in terms of breast cancer, so lifestyle factors, obesity, excess alcohol, things that can accentuate their risk of developing breast cancer, may have greater impact on breast cancer risk than HRT. So a small increased risk of developing breast cancer, obviously. The risk is greater with combined HRT than with estrogen only. So because progesterone that is actually the main culprit there. HRT is unlikely to increase risk of breast cancer in women who are younger than 50 years. And the risk of exposure from HRT should be counted from age of 50, which is average age of natural menopause. Micronized progesterone and dihydrogesterone may be the safest progesterones when you're talking about breast cancer risk. Now, in terms of VTE, because HRT increases the risk of VTE, but individual risk depends on other risk factors, and risk generally is low in early postmenopausal years. So oral HRT preparations carry the highest risk. Of course, transdermal estrogen appears safer as it avoids the first pass liver metabolism and doesn't activate clotting factors. But of course, here they say that's yet to be confirmed by randomized control trials. Micronized progesterone, which is eutrogestan, appears to be the safest progesterone, but more data is still needed actually. In terms of cardiovascular disease risk and HRT, so cardiovascular disease is the commonest cause of death in postmenopausal women. HRT does not increase the risk of cardiovascular disease in women who are less than or younger than 65 years. HRT may be cardioprotective in younger postmenopausal women, those who are younger than 10 years of age. But evidence is not strong enough to recommend it as the primary prevention of cardiovascular disease. In terms of stroke, so oral HRT increases the risk of stroke because the transdermal preparation appears to be safer in that regard. Risk of cardiovascular accident depends on other cardiovascular risk factors, but is generally low in this age group. Ovarian cancer, a slight increased risk of ovarian cancer with HRT, suggested from epidemiological studies, although causation cannot be inferred. Now, the forms of HRT, we have types of HRT, estrogen-only HRT. Of course, we have the combined HRT, which could be sequential combined or continuous combined. Now, for the estrogen-only HRT, for women who have had a total hysterectomy, or those who have IUS in situ, now, unopposed estrogens cause endometrial proliferation. Women with a uterus must have progesterone to stop this, obviously. And that's where the combined HRT comes in. So sequential combined HRT is for perimenopausal women. Since some endogenous hormone production will lead to irregular bleeding on a continuous regimen. Now, a woman would be on daily estrogen with sequential progesterone, usually in the last 12 to 14 days in a month to trigger a bleed. So which means you'll be on estrogen only for the first 14 days, for instance, and then move on to the combined one, which is estrogen and progesterone for the second half of the month. Whereas in continuous HRT, you should be on daily estrogen and progesterone every day. And that's for women who are postmenopausal, which means more than 12 months since their last menstrual period. And it says swap from sequential combined to continuous combined after more than 1 year of sequential HRT or age more than 54 years. If she's older than 54 years and 55 and above, then we want to switch her from the sequential combined to the continuous combined. Which HRT should we be using? Questions to ask yourself: does she have a uterus? If yes, does she require contraception? If she's less than 55 years and she's sexually active and she's menstruating, contraception, does she require? So contraception is not required if she's less than 50 years and she's been amenorrheic for 2 years or longer. If she's more than 50 years and she's been amenorrheic for more than 1 year or longer, then she doesn't require contraception. Now, it says, does she require contraception? If yes, offer any of the following HRT contraception options. So estrogen only pill or patch or gel or spray. And of course, you can use the Mirena coil, 52 milligram of IUS. You can do combined hormonal contraception, sequential combined HRT, plus progesterone only contraception, which can be the pulp or the implants or the depot injection. If she's amenorrheic with progesterogenic contraception, could use continuous combined HRT instead of sequential. Stop hormonal contraception at the age of 55 years. These are the available HRT preparations. Got the oral, got the patch. It's good to know some of the names. So Phenostone, sequential combined. We have Phenostone Conti, which is continuous combined. We have LS Duet, which is sequential combined. So LS Duet. We have LS Duet Conti. You go to patches. We have Everos Sequi. And we have the Evero Conti. Fem7 Sequi. Fem7 Conti. Cleofem and Cleovans are continuous combined. So the two Cleos, the Cleovans and Cleofem are continuous combined. And then if a woman has no uterus, so she's undergone a total hysterectomy, or she has a Mirena coil in situ, then obviously she needs only estrogen. She needs estrogen only HRT. And the available options could be, of course, the oral estrogen, estrogen patch, estrogen gel, estrogen spray. And for the patch, we have the LS Solo, Extra Dem, Evorel. So Evorel, that's Evorel 25, 50, 75, 100 microgram patches. As Extra Dots patch, the Fem7 patch. And for the gel, we have the Estrogel, we have the Sandrina, and the Estradiols. We have progesterone or progesterone only, so to be used with estrogen only HRT if she has a uterus. So like hydroxy progesterone acetate tablets, Pymano, I have utrogestan, which is the micronized progesterone, can be used vaginally, off license. Can be used vaginally, off license. We have the Mirena coil, levonorgestrel, Mirena, and some other brand names. Other HRT preparations, Tibolone. I've never really had to prescribe Tibolone. I've never really seen a patient that is on Tibolone for HRT, to be honest. Let's see, still on HRT. I've looked at some of these things already. Less solo estrogen only. And estrogen only patch. So my non-estrogen tablets, so it can be used as estrogen, 1 milligram to milligram. But sequential compound, we've seen LS duets, we've seen Phenostone, we've seen Phenostone Conti for the continuous compound, we've seen LS duets Conti for that. Understanding risk of breast cancer. A comparison of lifestyle risk factors versus hormone replacement therapy. Difference in breast cancer incidence per 1,000 women aged 50 to 59. Approximate number of women developing breast cancer over the next 5 years. So it's 23 cases of breast cancer diagnosed in the UK general population. Additional 4 cases in women on combined hormone replacement therapy. So out of 1,000 women who are aged 50 to 59 years, 23 cases, 23 were diagnosed with breast cancer. Now, there will be an extra 4 for those who are on HRT, combined HRT. For women who are on estrogen only HRT, the risk is less actually than the general population, which means estrogen only HRT could actually confer some protection in terms of breast cancer risk. For people on combined hormonal contraceptives, an additional 4. So combined HRT and combined hormonal contraceptives actually increase the risk of breast cancer. Whereas estrogen only HRT actually appears to be reducing that risk. Women who drink more than 2 units of alcohol per day use more than 40 units of alcohol a week. That's an increased risk, additional 5 out of 100. So you now be having like 28. So 3 additional cases in women who are current smokers. So if you're currently smoking, it also increases your risk of developing breast cancer. Additional 24 cases in women who are overweight or obese. So being overweight or obese significantly, massively increases your risk of developing breast cancer, actually, from what we can see. 7 fewer cases in those who take at least 2.5 hours of moderate exercise significantly reduces your risk of developing breast cancer. Significantly, a lot. Whereas being overweight or obese, not being a smoker, drinking more than 40 units a week, being on combined hormonal contraception, combined HRT, increase that being on estrogen only appears to be reducing that risk. Okay, so start. Let's look at something else. The next thing here is antibiotic prescribing. The one thing I really want to look at. Diverticular disease. Patient has diverticular disease. We'll just look at something very quickly. So, diverticulosis or diverticular disease do not offer antibiotics. You advise the patient on diet and lifestyle because of the disease and likelihood of progression, symptoms and symptom management, for example, paracetamol for pain, bulk forming laxatives for constipation or diarrhea. Symptoms that indicates complications or progression. So you look out for symptoms. When and how to seek medical advice for people with acute diverticulitis, also advise of possible investigations and treatments, the risk of treatments and how invasive these are, the role of surgery and outcomes. Like the person's having acute diverticulitis, which is a flare, the person is systemically unwell, then you consider not prescribing antibiotics. The person is systemically unwell or immunosuppressed or with significant comorbidities or does not meet the criteria for referral or suspected complicated acute diverticulitis, then you need to be offering oral antibiotics. And you still have to give them these advice on diet, exercise, lifestyle, cutting down on alcohol, smoking, safety netting for when symptoms will get worse, what to do, how to seek help. Hospital management of suspected or confirmed complicated acute diverticulitis, including suspected diverticular abscess, you offer intravenous antibiotics. You are admitting the patient, obviously. A review within 48 hours or after scanning if sooner, and consider switching to oral antibiotics where possible. If uncomplicated acute diverticulitis is confirmed by scanning, review the need for antibiotics and discharge. If diverticular abscess is not confirmed by scanning, review the need for antibiotics for diverticular abscesses less than 3 centimeters. Switch to oral antibiotics when possible. So that the antibiotics typically we want to be using things like amoxicillin, which first line. Alternatives would be cephalexin with metronidazole combination, trimethoprim with metronidazole combination, ciprofloxacin with metronidazole combination. polymyalgia rheumatic management, Hashimoto's an inflammatory muscle condition. So typically the treatment is with steroids. Treatment regimen or regime to be tailored to the patient, or treatment is for 1 to 2 years. So prednisolone 50 milligram per day for 4 weeks, then you step down to 12.5 milligram daily for 4 weeks. So every 4 weeks, you're stepping down, reducing dosing to 10 milligram daily for 4 to 6 weeks. Then reduce to 1 milligram every 4 to 8, reduced by 1 milligram every 4 to 8 weeks, or then slowly tapering reducing. Using higher starting dose than 15 milligrams associated with more complications and will make it more difficult to bring down the steroids. So usually you start at 15 milligrams of prednisolone a day. Follow the patient up at 2 weeks. Evidence in favor of polymyalgia if patients reported global improvements in symptoms of over 70% within a week. Normalization of inflammatory markers within 4 weeks. You have to repeat the blood test, CRP, ESR, whatever you're checking, and then normalize within 4 weeks. Really suggests that actually this patient likely had a polymyalgia. Be vigilant of making differential diagnoses as described above. Now, relapse is common, but normally responds to restarting or increasing the dose of steroid to the last effective dose. The person has frequent relapses, or it's not possible to taper the steroids, refer to specialist review to consider disease-modifying anti-rheumatic drugs, DMARDs. There may be needs to be differentiated from non-inflammatory aches and pains, and can be confused with corticosteroid withdrawal symptoms, which can cause fatigue and myalgia. So we're looking at gout management. Obviously, we have acute gout and then gout prophylactic treatment. So managing acute gouts often NSAID coaches in a short course of oral corticosteroids, typically prednisolone. Taking into account comorbidities, prescriptions, and preferences, consider adding a PPI with NSAID or prednisolone. NSAIDs or colchicine unsuitable or ineffective, consider an intra-articular or intramuscular corticosteroid injection. Do not offer an interleukin-1 inhibitor unless NSAIDs, colchicine, and corticosteroids are unsuitable or ineffective. Refer to rheumatology before prescribing, so you don't, that's the medication that rheumatology should be one. What it means is that this patient is having acute gouts, it's not settling. You've tried NSAIDs, colchicine, or prednisolone, and this patient's acute gout is not settling. You might need to refer that patient to the rheumatologist to consider some DMARDs. Advice that applying ice packs to the affected joint, cold therapy, in addition to taking prescribed medication, may help relieve pain, so cold ice pack. Consider a follow-up appointment after a gout flare has settled to measure serum uric acid, because I think the current teaching is that you can actually check uric acid level even when the patient is having acute gout flare. Provide information leaflet or link, assess lifestyle and comorbidities, review medication, and discuss risk and benefits of long-term uric lowering therapy. So lifestyle, reduce alcohol, smoking cessation, exercise, diets, you just send the patient on a dietary link on purine, low purine diets. Information and support, provide tailored information at diagnosis and during follow-up appointments, explain causes and symptoms and signs of gout. Explain that the disease progresses without intervention because high levels of urate in the blood lead to formation of new urate crystals. Any risk factors for gout they have, including genetics and family history, excess body weight or obesity, medications they are taking, typically diuretics, diseases like chronic kidney disease, hypertension. Explain how to manage gout flares and the treatment options available. Explain that gout is a lifelong condition that will benefit from long-term urate lowering therapy to minimize urate crystals and prevent flares. Bring the TOFI, prevent long-term joint damage, explain where to find other sources of information and support, such as local support groups, online forums, and national charities. Diet and lifestyle. Explain that there's not enough evidence to show that any specific diet prevents flares or lowers serum uric acid. So there's not, available guides to follow a healthy balanced diet. That excess body weight or obesity or excessive alcohol consumption may exacerbate gout flares and symptoms. The patient might ask you about purine diets. There's no concrete evidence that low purine diets might actually reduce the risk of gout flares, but you can always send them a dietary link or advise them to speak with a dietitian to get more information. Now, long-term gout management, which is essentially the urate lowering therapy. I explained that the disease progresses without intervention because high levels of urate in the blood form new urate crystals. Gout is a lifelong condition that will benefit from long-term urate lowering therapy. Ensure people understand that urate lowering therapy is usually continued after the target 7 uric acid level is reached. And the ULT is typically a lifelong treatment. Consider rheumatoid urticaria if diagnosis of gout is uncertain. If treatment is contraindicated, not tolerated, or ineffective, if they've had CKD stages 3B to 5, GFR categories 3B to grade 5, if they have had an organ transplant and they have gout, you want to get advice, seek help, advice from the rheumatologist, obviously. Offer urate lowering therapy using a treat to target strategy to people with gout who have multiple or troublesome flares, CKD 3 to 5, diuretic therapy, TOFI, chronic gouty arthritis. Discuss the option of urate lowering therapy with people who have had the first subsequent gout flare who are not within the groups listed above. So, when the patient is having their first gout flare, you need to be discussing the option of urate lowering therapy with them. First-line treatment offer either allopurinol or febuxostat. Offer allopurinol to people who have with gout, who have major cardiovascular disease. Second-line treatment, consider switching to allopurinol. So if you started with allopurinol, patient not tolerating it, you can switch to febuxostat. If you started with febuxostat, patient not tolerating it, you can switch to allopurinol. Now, the treat to target strategy means start with a low dose of urate lowering therapy and use monthly serum urate levels to guide those increases accelerated until target serum urate level the target is reached, and target is typically below 360 micromole per liter. So start urate lowering therapy at least 2 to 4 weeks after a gout flare. At least 2 to 4 weeks after a gout flare has settled. Sometimes it is difficult, you find that it's difficult to actually get the flare down. Some people advocate starting the urate lowering therapy at the same time treating the acute gout. If the flares are more frequent, urate lowering therapy can be started during a flare. So it's difficult to get that safe space after a flare. You may need to start it while the patient is on the NSAIDs or colchicine or prednisolone to settle the flare. Target serum uric acid levels. Aim for below 360 micromole per liter, which is less than 6 milligrams per dl. Consider below 300 micromole per liter for TOFI or chronic gouty arthritis. Ongoing frequent flares despite serum uric level below 360, then you want to push the target to less than 300. Consider annual monitoring of serum uric acid in people with gout who are continuing urate lowering therapy after reaching their target serum levels. Discuss the benefits and risk of taking medications to prevent gout flares when starting or titrating the ULT. For people who choose to have treatment, offer colchicine while target serum level is being reached. If colchicine is contraindicated or not suitable, consider a low dose of NSAID or low dose oral corticosteroid. Consider adding a PPI, taking into account individual risk factors for adverse effects. Do not offer interleukin-1 unless NSAIDs, coaches, corticosteroids, and rheumatologist needs to be the one prescribing that actually. And when it comes to sick day rules, it's quite something that you need to be familiar with because a patient could actually, a case could be like patient is having diarrhea, dehydration, not really drinking, lethargic, patient is diabetic, patient is hypertensive on certain medications. I need to identify those medications that need to be held temporarily until the patient's drinking has improved and the patient is feeling better. Medicine sick day guidance when you're unwell with any of the following, vomiting or diarrhea, unless only minor. If you're having fever, sweat, shaky, then stop taking the medications listed over leave. It starts when you're well after 24 to 48 hours of eating and drinking normally. If you're in any doubt, contact your pharmacist, GP, or nurse. Medications you need to stop on sick days, the ACE inhibitors, the ARBs, the NSAIDs, the patients on ibuprofen, diclofenac, naproxen because of the risk of AKI. So similar to the ARBs and ACE inhibitors, risk of AKI, even hyperkalemia from these two. Diuretics, obviously, because of the risk of prevenal AKI, So you have to hold glutamate, spironolactone, indapamide, benzoyl and then metformin because of the risk of lactic acidosis. It's good to actually pay attention to this medication. Each time you see any of these medications, you need to ask yourself, should the CKD go apply here? Should I be advising these patients hold off their medication or not as part of my management plan? There's still a sick day rule for who with adrenal with Addison's disease, primary hypoadrenalism. So what means that these patients are at risk of having adrenal crisis. So sick day rule, moderate intercurrent illness. Usually these patients are on hydrocortisone and even fludrocortisone steroids. So when they become unwell, when they're having a surgery or something, they usually need, if they're well, they're septic, or they're just having gastroenteritis, or they're having a febrile illness, and they're undergoing a surgery. Typically, they might need, very likely, they will need a higher dose of steroids to prevent an acute hypoadrenalism. So moderate intercurrent illness, fever, infection requiring antibiotics, surgical procedure under local anesthesia. They use to double the dose of glucocorticoid, double the dose of their hydrocortisone, which is glucocorticoid. Now, see if they have severe intercurrent illness, persisting vomiting, like a gastroenteritis, during preparation for colonoscopy or in case of acute trauma surgery, then hydrocortisone 100 milligram intravenous at onset, followed by initiation of a continuous. So either you give IV hydrocortisone or IM hydrocortisone, followed by regular hydrocortisone IV or IM. Please tell them that. Teach the patient and parents or partner how to self-administer and inject hydrocortisone. Provide them with a hydrocortisone emergency injection kits, hydrocortisone 100 milligram hydrocortisone for injection. So like a pre-filled hydrocortisone. If you provide them with, so if they're feeling very unwell, symptoms of hypoadrenalism and insomnia crisis, the things like extreme fatigue, sweating excessively, feeling very unwell, feeling lightheaded. They could have, of course, risk of hypotension, so they might start having palpitations, lightheadedness, sweating excessively, and things like that. So at that point, they probably use injecting themselves and then obviously calling the ambulance for help. Still on sick day for adrenal patients preventing adrenal crisis. So what to do? Double your daily hydrocortisone or prednisolone dose if you have a temperature of 38 degrees or more. If you get a bout of cold, flu, diarrhea, or that infection that makes you feel poorly or weak. If you break a bone, like a fracture, suffer from any similar significant injury, significant trauma. For hydrocortisone users, if you take less than 20 milligrams of hydrocortisone in total, your regular daily dose go up to 40 to double as a minimum dose during stress and illness. This can be done by doubling your usual 2 or 3 daily doses. Patients can usually take phenytoin. Patients who usually take phenytoin should switch to a regular immediate release hydrocortisone preparation and take 10 milligrams orally every 6 hours. If your dose of hydrocortisone has increased to 50 milligrams or higher, stop your fludrocortisone. You can start it again once you taper it down. But typically, the hydrocortisone, which is glucocorticoid, and then fludrocortisone, which is mineral corticoid replacements. So if you're now, what I say, like your hydrocortisone, maybe because of the intercurrent illness or severe stress or surgery, trauma, because if you keep increasing your hydrocortisone dose and you're now taking 50 milligrams or more, then you probably need to hold up your cortisone for a bit. For prednisolone users, if you take less than 5 milligrams of prednisolone in total as your regular daily dose, go up to 10 milligrams daily as a minimum prednisolone dose during stress and illness. This can be done by doubling your usual 2 or 3 daily dosing. In this case, the patient can take 5 milligrams 4 times a day or 10 milligrams. 10 milligrams 3 times, so 30. So 5 is 20 milligrams, 30 milligrams. For how long? Double your dose for 48 hours. If you're feeling better, go back to your usual dose. If you don't feel better after 48 hours, continue to double your dose and speak to your GP or your endocrine nurse or doctor for more advice. If you are prescribed antibiotics, continue to double your dose until you finish. Continue to double. It doesn't mean every 48 hours, so just continue on that double dose until you finish the course or feel completely back to normal. It's important that you gradually taper any increased dose and your cortisone down too. So don't just assume you were on 20 milligrams a day of hydrocortisone. You now double it to 40. It's advised that you might need to step down to 30 and then probably 25, probably, and then, yeah, you don't just jump back down to your. If you double this for just 48 hours, then very likely you might just go right back to your normal dose. 48 hours is not too long. What if I have a temperature of above 39? If your temperature goes above 39, take 20 milligrams hydrocortisone every 6 hours and immediately seek medical advice. So the bottom line in this thing for the SCA is that you have to identify that the patient might need to double their dose. And they also need to have the refilled hydrocortisone injections. And they start feeling unwell, they should double their dose and speak with someone. They need to have they obviously need to have a steroid emergency card. A steroid emergency card that explains. Yeah, it's written there. So that's the NHS steroid adult emergency card. So what it's written there. Emergency treatment of adrenal crisis, immediate 100 milligram hydrocortisone IV iron injection followed by 24 hours of continuous IV infusion of rapid rehydration with sodium chloride, layers with independent injecting. The patient should always have the steroid card. And this is a pediatric steroid card, which of course will be dosed based on the patient's weight, body weight. Yes, guys.